We're going to now have time for questions from the audience. If I could ask Suzanne and Jeff to join me.
Okay.
Yep, so we learned that Jamie Robinson has the answer. We just need the rest of the world to listen. We also learned that we are living longer, which is a good thing. So hopefully the speakers that you just heard maybe give you some food for thought. So we have about 10 minutes to open it up for the audience to ask some questions of these very esteemed panelists. So do I see any questions from the audience? Yes, we'll just get a mic right over here because we're videotaping. Perfect, thanks.
So just for some information, there was a point, I think Dr. Joyce mentioned, that Covered California has a low deductible. In fact, our silver deductible is $2,500, which I don't think you'd call low. But the reason it's that high is that we exempt ambulatory care from the deductible and have a lower copay or coinsurance for primary care than specialty care.
Thank you for the clarification. And we're getting a little bit of rain. All right, Mr. Steve Goff over here.
This is a question more about the pricing issue. In my work over the years, I've seen that physicians and hospitals have been willing to take substantially less money for capitation than for fee-for-service, and there's a lot of reasons for that I won't go into. But one of the numbers I've seen is physicians are willing to take about 120 to 130% of RVRVS on a capitated basis as their take-home, and about 230 to 240% on a fee-for-service basis. And what I'm wondering is, why aren't we seeing more capitation? I practice in California. I haven't seen a lot more capitation since 2002 in California, and as I travel back east and represent clients back east, I see almost no capitation. And I just don't understand why that solution, which gets rid of some of the perverse incentives and gets rid of some of the added load on top of healthcare costs, isn't more prevalent.
Great question.
I'll take a whack at that one if you want. We'll call it the John Rother question. If capitation is such a great idea, why don't we see more of it? All right. Well, in the state of California, we actually see less of it. Capitation has been in decline. There was a nice little report put out by Laura Tolan from the California Healthcare Foundation a couple of years ago. Take out Kaiser, which is a success story in California. The non-Kaiser HMO product and capitation has been in free fall for the past about decade, and no sign of turnaround on that. So it's kind of like, well, why? Why? Because capitation was California's gift to American healthcare, right? And I guess that there's a variety of things going on there. Partly that the PPOs are winning. The thing is partly because they're high deductible and that makes them cheaper. But it's also that a lot of the delivery systems that take the capitation, one day they kind of ask themselves, well, why am I doing this low capitation thing? Now that I'm all consolidated, why don't I do the high capitation thing? Right? And so that actually on a PM-PM basis, the HMO product is more expensive than the PPO product. And this is a controversial thing. People argue about the data on this. But even benefit design adjusted, and there's some experts in here that can maybe control that. But my understanding is that in other words, taking out the deductible, benefit design adjusted, the HMO product in California is more expensive than the PPO product on average, and that's why the PPO is growing, not because people like the PPO, because it's simply got a lower premium in the individual market as well as in the employer market.
Suzanne, you.
I just want to make sure we have time for lots of other questions. I'll just give a very simplistic answer, which is that physicians and hospitals that are not well in command of their spending information, their quality information, are loath to take on risk. And we're seeing that not just with capitation, but also with what the new phrase is shared risk arrangements, which is really fee-for-service payments on a daily basis that get reconciled at the end of some period of time against a spending target. And the growth in that, which my organization measures on a national basis, has been extremely slow. We're expecting that it's going to convert as accountable care organizations have been around longer. They're sort of like HMOs put together with Band-Aids, and that after a few years of experience, they might be willing to go from a shared savings arrangement to shared risk, which is sort of like faux capitation. That's what we're seeing.
You agree, Jeff?
I agree.
Okay.
All right, how about any other questions? All right, we have a gentleman here.
Hi, and this would be for anybody who wants to take it on. Kaiser's been viewed as the holy grail in terms of vertical integration or delivery system integration for so long, and at the same time, just about each of you have talked about the dangers in consolidation that's going on horizontally. And it seems to me like those two outcomes run into each other, and how do we avoid that? How do we get integration without domination?
I think it really depends on what the motivation is for the providers coming together. I wish the stories were, we want to come together because we have a dream of how wonderful we can make the patient experience. But that's not usually why they come together. And because of that, the intrinsic motivation that brings them together is not necessarily connected to the outcomes that we'd like it to be. And so I think that's why we see higher prices and not better quality. Of course, there's bumps in the road as different cultures come together and they try to figure out how to work together, even with different EHRs, different ways of communicating data about patients. But I think the motivation is rarely the one we want it to be.
Great. Question here right in the front for Jack.
Yeah, hi. Great discussion. So I'm Jack Lew, and when I was running the American College of Cardiology, I was witness to a wildebeest migration of cardiologists from outside practice settings to hospital employment. And the reason was because the HOPS payment system, even from the feds, obviously pays a lot more than the same services in the outpatient side. And Congress has said for years that they're going to rectify that. Eventually they're going to change it. We'd probably have a reverse migration at that point of practitioners. What do you think about that in terms of that differential and the federal impact on it?
I'm happy to answer that. There's, I think, going to be increasing attention to these site differentials, and employers are starting to clue in and think about benefit design, network design in terms of where to get people access to care at the right site in terms of what the amount is that you should pay. But a lot of this is really hidden for the consumer. You might go to the same doctor you've always been to, but because they've been acquired by a system, suddenly you're paying a facility fee that didn't exist. And that's exactly the point you're making. There was money to be made by those relationships. And I think if MedPAC recommendations are listened to and those site of service differentials are done away with, then we would see perhaps some disintegration or deconsolidation.
If I may add to that, I think that there is clearly, the lowest hanging fruit in saving money in the U.S. healthcare system is moving care from acute settings to less acute settings, from the hospital base to the freestanding, from the freestanding to the physician office, from the physician office to the home. I mean, that's the, we might call that improvement in what the economists would call static efficiency. But I think that the greatest gain from having a better incentive structure for the patient, could be some version of deductible, reference pricing, what have you, is that it creates a business case for entrepreneurs who want to build and develop new things, new settings. And I've talked to venture capitalists and other entrepreneurs, and they say, we can do it. We can do a lot more stuff now that used to, forget the hospital, it doesn't even need to be done in an ASC. We can use it in the doctor's office. We don't even have to be a specialist, it could be the primary care office or whatever. We can do it. The technology's there, but there's no market case for it because we'll be cheaper, but we won't get more patients, and therefore we can't get an ROI. Therefore we won't invest, and therefore. So I do think that from a dynamic perspective, if we had a system which was intelligent cost sharing and intelligent provider payment, we could see some of that moving further and further, and there would be a quality gain generally as well to move patients closer to their homes.
Great. All right, I think we have a question in the back, Mr. Darby.
Dr. Joyce, you seem to take a position that there's a role for insurance companies in the mix of healthcare in California. Back in the day, Medicare Part A and B functioned very well without, in the absence of insurance company influence. Before Part C got to be popular. So the question becomes, with Mr. Rother's position that 30% of healthcare is not related to healthcare, it's probably insurance company sales and administrative cost. So in view of the fact that Medicare Part A and B did function without insurance company influence, suggests that maybe that 30% could be applied to some other system, single payer maybe, that could reduce costs.
One of the advantages of a sort of a running through the private insurance system is so that basically I think it's for political not to run into the sort of nationalized medicine and government-run medicine and healthcare system. And I think you could do it with a regulated insurance market. Basically take a for-profit to, we're going to pay you as administrators, that's it, to administer these plans. I think it's for political expediency, and I don't think you have to have a for-profit sort of high administrative cost insurance system or underlying it.
If I could just make a prediction. We're seeing a tremendous growth in Medicare for Medicare Advantage plans to such an extent that it looks like that's really the future of the program. So what does that mean? That means that you have a universal entitlement that's funded through taxes largely, but administered through private plans. And question is that going to work for the future? Because I think that is where we're headed.
All right. This concludes our question and answer period. I'm sure all of you are very hungry. So with no further ado, I'd like to thank the panel that we had today.